Welcome to a new episode, this time with Professor Rainer Dziewas, a neurologist and expert in the field of swallowing and swallowing disorders. For this episode, we asked Rainer to explain how swallowing works on a neurophysiological level, because we believe that for dysphagia clinicians like us, understanding the underlying neurophysiological mechanisms is essential for a solid assessment and an effective intervention. So get ready for a trip from the brain to the swallowing muscles and join us as we discuss the factors that can affect physiological swallowing. We recorded this episode in person at the annual meeting of the German Society for Dysphagia, so please excuse the background noise in this episode and enjoy listening.
Hello, Rainer, and welcome to our Dysphagia Matters podcast. So just to give you, our listeners, a brief insight on where we are, and maybe you might hear some background noises. So we're currently in Berlin, in Germany, at the German Dysphagia Conference, and we're sitting here in person, which is really nice. We always enjoy it. So welcome.
Yeah, thank you. Thank you for having me here for your podcast. It's a pleasure.
Thanks for taking the time. In a previous episode, for example, we've already talked about the history of our understanding of neural swallowing control. So what is our current state of knowledge about which structures in the brain are involved in swallowing control?
Swallowing control, in my opinion, is one of the most complex tasks of the human brain and adjacent structures. We have a broadly scattered cortical and subcortical swallowing network, which is connected to the brainstem swallowing centers, from where the swallowing muscles are targeted by many cranial nerves. More in detail, we have cortical structures which are supplementary motor areas, primary sensory motor areas, and secondary sensory areas that are controlling the swallow. So it's motor and sensory control, and it's cortical structures, subcortical structures, and brainstem swallowing centers, as well as I said, cranial nerves and swallowing muscles.
Yeah, so you've already mentioned it. Our previous knowledge was, or assumption was, that swallowing is a basic function and therefore controlled by the brainstem. Why is this assumption outdated, and what is the current evidence base on this?
Yeah, it's a very good question. And indeed, it is, as you said. I would assume that when I started with swallowing research, and this was really 2 decades or more ago, it was really believed that the most important part of the swallow is coordinated in the brainstem and that it's a purely reflexive procedure. Now we know that the voluntary part of swallowing control, which is mainly oral preparation and oral stage, is controlled by cortical and subcortical swallowing structures apart from the brainstem. And these structures are important for the oral bolus control and the oral bolus transfer, whereas when the swallowing reflex kicks in, it's mainly brainstem. But even the swallowing reflex is modulated by the upstream cortical control. And this is really, and I'm remembering back to this episode with joy, this was mainly result of a study I did in 2003, where we used magnetoencephalography, and within MEG, we analyzed the cortical control of the purely reflexive swallowing, which we elicited with the subject sitting in the MEG. So this was one of the first key studies we did with regards to the cortical control of swallowing, and it showed that even the swallowing reflex has a cortical control.
And when we talk about control, what are we talking about? How does controlling work exactly? So how does the brain communicate with the muscles, the other way around, and also the brain structures with each other?
That's a difficult one. So obviously, the many different cortical structures involved in swallowing control are connected within each hemisphere, but there is also interhemispheric connection. It's a truly widespread swallowing network with many brain areas interconnected. Of course, the knowledge about these interconnections or these connections is growing. It's growing because imaging techniques are advancing. in my opinion, the best clinical model we have for a acute disturbance of the swallowing network is acute stroke. If you look at acute stroke, and it's quite important to discuss this when talking about the cortical control of swallowing. If you look at acute stroke, you have the phenomenon and the clinical observation that immediately when the stroke hits the brain, the swallowing network is critically disrupted. And in many patients, as you know, the incidence of dysphagia in stroke patients in the acute stage is high. Immediately, swallowing function deteriorates, and patients during the first days are at a highly increased risk of complications. Interestingly, this acute dysfunction seems to improve in many patients. So the dysfunction that kicks in acutely then improves rapidly. And this is not related to reperfusion of the brain, but is indeed due to the diasthesis induced by acute stroke leading to malfunctioning of structurally intact brain regions improve within the first, I would say, 10 to 14 days post-stroke. And I think this is pathophysiological-wise one of the most important findings we have had during the last 10 years.
Okay, and apart from maybe stroke, are there also any other factors that might affect this communication of the physiological swallow?
Of course, diseases interfere with the cortical swallowing network. And of course, it's not only acute stroke, but acute stroke is important because of its high incidence, but also other neurological diseases interfere with the swallowing network. Chronic progressive neurological diseases like Parkinson's disease, dementias, but also diseases that do not affect the brain itself, but lead to an impairment of the upstream sensory information. So, for example, another very common situation is the patient on the ICU, post-extubation, still with saliva in the pharynx and mainly also in the larynx with mucosal edema. And because of this, impaired sensory feedback. And this impaired sensory feedback reduces the activity of the swallowing network and by itself causes dysphagia. So here we have the situation that a peripheral problem, not directly related to the central swallowing system, induces also critical dysphagia with related complications.
And then we've just heard a brilliant talk by Paul Muhle, and I think it's also the work from Sonja Suttrup-Krüger on how dual tasks, both motor dual tasks as well as cognitive tasks, can influence our swallowing control. Can you maybe, as you are also part of this research team, can you maybe give us an overview how this interconnects?
Yeah, I think this is in detail, if you look at the neuronal level, is possibly not completely understood. But what we learn from these observations, which are also clinically highly relevant, is that the swallowing system really needs a lot of resources. And it's, again, as you mentioned, if you look back in history and realize that we 20 years ago thought that it's purely reflexive, that it's brainstem and that cortical resources are not needed. It's the contrary. We need cortical resources for controlling swallowing. And if we have maybe also reduced cortical resources because of dementia, for example, then there is indeed a breakdown of the cortical network, which just induced by the subject needing to remember a 6-digit number is reduced in a way that simple swallowing, so to say, is not fully working. So it's indeed, I would say it's a question of cortical resources that are in the dual task situation critically limited. I can't say, I guess it's prefrontal. It's if you look on the cortical areas that are activated and that you need to activate for dual task, it's mainly prefrontal areas. But I don't know more details about it. But I would say it's a matter of cortical resources that are critically diminished in these dual task situations.
I think the 6-digit number was 604312, was it?
Yeah, maybe, brilliant.
maybe not. Sorry.
If you could take us on a journey through the brain during a swallow. So where does it start? In which area? What's it called? What's it responsible for?
Yeah, I understand. So, yeah, well, what I'm now saying is still, I would say, the best hypothesis we have derived from many brain imaging studies. But we start outside of the motor system. So at the beginning, I would say, if you consider to start eating, to have a bite, then a widespread network, mainly recruiting prefrontal areas, recruiting parts of the limbic system, which you know is important for control, for emotional control. Effective stimuli are coordinated here. So it starts there. And it starts, of course, in the sensory system. So prefrontal areas, sensory system, parts of the limbic system are activated. Then when the motor planning starts or motor execution starts, it's the motor areas that are recruited. So it's a supplemental motor area and it's the primary motor cortex together, because it's sensory motor together with the primary sensory cortex. And then we have, of course, with the primary motor cortex, activation of the cortico-bulbar tracts, which connect the cortex with the brainstem. And from here, the next step is activation of the brainstem swallowing centers. And then, of course, the cranial nerves that transfer the motor program to the different swallowing muscles. I think this is basically the top down. And then, of course, there is this constant feedback of sensory nerves that constantly feedbacks the information of, yeah, as you said, how big the bolus is, volume of the bolus, temperature of the bolus, taste of the bolus, constant feedback of this information to cortical and brainstem swallowing centers to modulate the whole swallowing process, because you don't have only one swallow. There is one swallow, there's the next one. And it's a constant process of downstream motor execution and upstream sensory feedback.
So as you've already talked about the term reflex, we would like to go into that term a little bit in more detail. So first of all, what does reflex mean in general?
Yeah, I think it means that something is done or is happening without voluntary control. There is an input and it's an immediate reflex output without many interneurons interconnected. So it's a reflex loop that bypasses cortical structures, for example, the cortical swallowing network, if we are talking about swallowing.
Yeah, okay. So, and that makes totally sense if we talk about swallowing, that it's not fully reflexive then. So,
right.
Because as you've outlined, we do have the cortical structures that are part of the swallowing process. So part of the swallowing we can modulate voluntarily. I think there are also other factors how we can influence the swallow, but depending, for example, on bolus size, viscosity, etc., the swallow physiology varies as well.
Right.
Can we still call swallowing reflexive then? I think in the Research Society, I feel sometimes like there are two teams. There's one team who is saying we should not call it a reflex, it's more the initiation of pharyngeal swallow. And there's kind of team reflex. Which team are you on?
Oh, I'm not aware. It's a very good question. I've not been aware of this discussion. I would say indeed, if we are talking about the swallowing reflex, it's indeed the initiation of the pharyngeal swallow. That's right. But I would still call this part reflexive. And from the...
Sorry, you mean the pharyngeal part?
Yes. I would still call the pharyngeal part reflexive, because during FEES, we may want to specifically test the pharyngeal swallow, so to say the swallowing reflex, in a patient where we are not able to test really oral boluses because of poor oral bolus control, because the patient is not cooperating and so on. But we are still interested in this single swallow reflex, and we test it by bypassing the oral cavity and injecting the swallowing material directly into the pharynx. And what you see there is, if the swallowing material, for example, a small amount of cold water reaches the trigger zones of this swallowing reflex, and here the word is again, if reaches the trigger zones of the swallowing reflex, this reflexive swallow, the pharyngeal swallow, is elicited. Therefore, I would still say, well, it's indeed the whole swallow has as one component this swallow reflex, which is indeed pharyngeal part of deglutition.
That's really interesting. So then, I mean, another topic of discussion is, do we really need to differentiate the different phases of swallowing, so oral phase, oral bolus transport phase, etc. And oftentimes it's said, well, for teaching, it's really helpful to look at the phases in particular. But in real life, swallowing doesn't happen in different phases. It's just one whole process, and so many different structures and functions interact with one another. So it's interesting because you now kind of pick the pharyngeal phase as one and disregard the other, kind of, quote unquote.
Yes, that's true. I think it's a valid question. I think that the differentiation between the different swallowing stages is not only for training or teaching. I use it in my daily routine. If you're asking this question in that moment, I visualize patients where you really see that this normal, I would say in a normal healthy subject process of swallowing, where one stage moves over to the next one and you can't really say where, what, when, what happens exactly, where this is disrupted and where you really see first oral prep and oral transfer, and then the subject tries to initiate the pharyngeal swallow. You really see that it's different, that the voluntary stage where the oral transfer is taking place is not immediately moving over to the pharyngeal stage. And there, in these conditions, mainly in patients with a delayed pharyngeal swallow, maybe because of impaired pharyngeal and laryngeal sensation, where this impairment leads to a dissociation of these two stages, which make me believe that it's there are different processes behind, and it's meaningful to distinguish them also clinically.
Okay, and I feel like this would be a wonderful opportunity to put some experts on this podcast for one episode and have a roundtable discussion.
For those of you who haven't listened to episode 26 with Maggie Lee Huckabee yet, we can highly recommend doing so. In this episode, Maggie Lee shares another perspective on the term swallowing reflex. Okay, let's move on to the implications for clinical practice, especially for people like us speech and language therapists. Why is it so important for us to include, for example, the cranial nerve exam in the diagnostic process?
Yeah, I think it's important. And I tend to start any investigation of a patient with a brief cranial nerve exam, because then if there is something wrong, you already have an idea what may happen if you do then the instrumental testing. For example, what you have in patients with dysphagia and with regards to cranial nerve impairments, maybe a tongue palsy or maybe a half-sided impairment, tongue and face, and then you may think, well, if these two cranial nerves, so 12 and 7th, has a problem, maybe the 10th also has a problem, and there may be hemiparesis of the pharyngeal constrictors. So if you do your cranial nerve exam, then you of course have implications for what you anticipate during further instrumental studies. So I think it's apart from everything else you need to do prior to starting your instrumental investigation, it's meaningful to look into the cranial nerves. So if you have the chance to study patients clinically, it's easy, it's absolutely risk-free without any side effects. You really should do it. It's not long-winded, it's a very comprehensive and clear-cut process.
So what else would you say should we assess, or which other assessments are there that you would recommend for us to use to get a solid impression of neurophysiology that our patient presents with?
Apart from dysphagia per se, and I think this was also topic of this conference, apart from dysphagia, there are other factors that are related to patient prognosis and the impact dysphagia has in the individual patient. So what you need to get an idea of is, of course, the level of consciousness, the ability of the patient to cooperate with your training and with maybe compensatory swallowing interventions, with diet changes that may be necessary and recommended, but if patients don't follow these recommendations, they are of not such a great use. And of course, oral hygiene and cough strength are very important and may have an impact on how you manage the patient. So there is much more than swallowing function that needs to be addressed during the initial assessment and during follow-up.
Yes, thank you. So I think our aim was to talk about the physiology or neurophysiology of swallowing but I realized it's so difficult not to talk about the pathophysiology. So we've talked about the diagnostic process. If we think about dysphagia interventions, what would you say do we need to consider regarding neurophysiology when we develop a new dysphagia treatment or intervention?
Yeah, that's also a very, very good question. I think you can't develop a swallowing intervention which is not, or most swallowing interventions will be related to the pathophysiology. And you rightly addressed that it's so difficult to talk about swallowing dysfunction without relation to specific disorders. So you need to consider which clinical condition, which disease group or disease you are targeting. And I think that the best example where we realize that we still don't fully understand what's going on. We know about the swallowing network and about the interconnection between different brain areas involved in swallowing control. But even in the simple, in seemingly homogeneous cohort of patients with a supratentorial stroke, one-sided supratentorial stroke, this is, I would say, quite homogeneous patient cohort. We don't know. If we now talk about central stimulation strategies, we still don't know which hemisphere to target. There are studies that suggest to target the non-lesioned hemisphere. There are also studies suggest to target the lesioned hemisphere, and there are studies that do both stimulation of both hemisphere and even studies that use intratentorial stimulation. And of course, it's stimulation and inhibition that can be used. So there is a variety of options here to stimulate the swallowing network. And it's unclear which works best. And it's also unclear how swallowing physiology and the control of swallow is really influenced by these types of stimulation. And the reason why it's so difficult is that you can, of course, look for clinical outcome. And this is, of course, the most important thing. So have interventions that produces good clinical outcome, because this is what we are working for. But you also, if you want to understand how it works, you need to do, apart from the stimulation and assessment of clinical outcome post-stimulation, you also need to assess the changes of brain physiology during swallowing, prior and post-treatment. And so far, there are very few studies that used sophisticated functional brain imaging in stroke patients combined with central stimulation strategies and have an idea what is the influence and the effect of these types of stimulations. And there are just so few studies because it's so resource demanding and complicated to study these vulnerable patients with these additional imaging modalities. And therefore, we are still stuck in a situation where we have ideas, but are not sure and need, possibly need further studies.
Yeah. And so currently, together with colleagues, we've been looking at swallowing characteristics in people with Parkinson's, and we tried to extract them from the literature. And we realized, well, even if the researchers found something on, for example, fees that seems to be abnormal or not normal, if they don't have a control group, we don't have enough data on normal, quote unquote, swallowing. So we don't really know, is it something specific to people with Parkinson's, for example, or is it just normal? Is it because of aging? Are there any other factors?
Yeah, that's also important. Control groups are important. You're right. Yeah.
And would you agree that we still don't know enough about just the normal swallowing physiology?
In particular in the aging population, because here we really have the problem that it's hard to grow old without being diseased, without being affected by anything. And if you have a patient with Parkinson's disease, who is, of course, obviously often also aging and of higher age, then it's difficult to say which is what. Of course, there are, I think, typical findings in Parkinson's disease, but in this particular group of patients, you can say that Parkinson's disease, possibly depending on the individual pathophysiology of this disease, and it's different from patient to patient, any swallowing dysfunction may occur. So it may be oral stage dysfunction, it may be pharyngeal stage dysfunction, and it may be esophageal stage dysfunction. So it's a complex situation where it's, I would say, easier to do a treatment trial with a simple behavioral swallowing interventions like EMST or Lee-Silverman voice treatment, then to have a proper setup for a study that really dives deep into the pathophysiology of this specific type of Parkinson's disease related dysphagia.
We've almost reached the end of this episode today. So to conclude, what does physiological swallowing mean to you?
Well, that's a good question. So I would say the physiological swallow looks so easy. If you do a FEES, it's over within, I don't know, maybe 2 seconds or so. It's so easy. It seems to be such a straightforward process. But in fact, if you go into the details, look how it's coordinated. It's, as I said, one of the most complex sensory motor tasks the human being is capable of. And it's resource demanding like hardly anything else we know.
Maybe to add to this, we had the chance to do a FEES, so Eula scoped me yesterday, and I've never done it this way before, and so other people were just saying, oh, can you do premature spillage, or should I do it? I'm like, okay, I'm gonna try it. And I was really surprised just looking at the screen and seeing like biofeedback in real time, how I could push the bolus like already on the epiglottis, and I was like, well, it didn't feel like it. I would have thought it was maybe at the very back of my tongue. So I was quite impressed how much you can modulate your swallow without making it.
Yeah, like... that's a beautiful example that again shows, and we come back to the first part of our conversation where we talked about swallowing and the difference between the voluntary and the reflexive part of it. And this really shows that you are able to modulate your swallow in an extent which clearly points to the fact that it's anything but purely reflexive. That's true.
Wonderful. Thank you so much.
Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphasiaPcast, or visit our website at dysphagiamatters.org. Take care, everyone.